especially in rural areas. And with respect to affordability, we found that it was not problematic in Latvia as when compared to other countries in this region. However, there are still large inequities in terms of affording the care in private sector, and you can see that 42% of women received at least partly care in private sector. The antenatal care seeking behavior in Latvia is quite high. You can see that 74% of women received at least 8 antenatal care visits, which is the recommended number. However, it is recommended to receive at least 4 postnatal visits, and here you can see that 12% of women only receive 3 or more postnatal care visits. To a lesser extent, lifestyle-related issues and health literacy were found to be barriers related to acceptability of care, and these factors can limit the care-seeking behavior. The study in Romania, Bulgaria, and Moldova revealed extremely high rates of cesarean sections, especially in Bulgaria with 53% and Romania with 61%. There was also insufficient number of antenatal care visits received, especially in Moldova, 38%, and postnatal care visits, especially in Bulgaria, with 17% of women receiving 3 or more visits. Women in all these 3 countries who received care, who were having health complications during maternal period, who gave birth through C-section, who birthed in public facility, and who had fewer antenatal care visits, were more likely to experience access barriers to adequate maternal care. And these barriers were related to 4 domains: availability, appropriateness, approachability, and affordability. Finally, the 5th study, which compared the inpatient maternal care users in Ukraine to inpatient care users that didn't use maternal care, revealed that with respect to affordability, maternal care users paid informally more often, higher amounts, and were requested to do so more often. With respect to appropriateness, the care satisfaction was found to be low in both groups, maternal care users and non-maternal care users. However, the maternal care users were more satisfied overall with the care, but also more specifically with treatment efficiency, with sanitary conditions, with access to diagnostic tests, and provider qualifications. In conclusion, the 5 access-related indicators are important for a comprehensive evaluation of the provision of maternal care. It is also important for the countries where barriers to access adequate maternal care are concealed by the relatively good macro-level indicators. Access to adequate maternal care is a multifaceted problem, and the action is required beyond policy level to ensure the access to good, adequate maternal care for all women. More efficient allocation of the existing resources and building on good practices are the starting points for reducing these access barriers. Thank you.
Dear candidate, thank you for this presentation. I give the word to the first opposition, which will be opened by Professor Bernd. He is chair of this assessment committee and professor of European public health at this university.
Dear co-author, thank you for handing over. Dear candidate, thank you very much for this overview of your PhD thesis that we read with pleasure and went through the different chapters to see how your research was done over the last years. If I remember right, you are a bachelor in European public health, where a lot of these European issues already were discussed, and 3 of those countries, Bulgaria, Latvia, and Romania, are now members of the European Union, and already for some time. My first question would be, do those countries that are members of the European Union differ from the results, outcomes, prevalences, incidences to Georgia, Moldova, and the Ukraine that are not members? So are there two groups or not, and do they differ? And the second one is, normally in such a setting one would ask, well, what can the European Union do? And the term European Union only appears 3 times in your thesis. 1 time in the text and 2 references use this term. That made me wonder, are there no possibilities of the European Union to bring about change? What would be your ideas, what the EU can do to help at least those 3 countries that are there, and of course in the neighborhood policy to help the other 3 too?
Highly esteemed opponent, thank you for compliments of my thesis, and thank you for your 2 questions. Thinking of how to go about those questions, the first one was about whether there is a clear division between European Union countries and those countries that are outside European Union. And I think, to me, it depends, what are we comparing? Are these mortality rates that we are comparing, or these are other indicators that we are comparing between the European and non-European countries? I have to say that maybe also a reason why there was not a clear EU and non-EU division in the thesis, because some of those issues are really interrelated, but they are going across the borders, but also so they are present in both EU and non-EU countries. You can see also, maybe I can open one of the slides where the incidence rates were there. That you can see in maternal mortality rates, and for example in Latvia with 19 per 100,000, and also in Moldova, Romania, but also in countries outside EU. So with respect to those indicators, I can say there is not a real clear division. You would expect that EU indicators would be better than in countries outside the European Union.
Oh, and study 3, you say Latvia, affordability not a problem.
So that's why I was saying it depends which indicators are we looking at. If you're looking at mortality rate, this is not clear, but when we are zooming into, there are clear differences. And for example, indicators such as affordability was really in Latvia not found to be a problem, but it was found to be a problem in Romania, which is also an EU country now. I think the underlying issues are different, and one of the reasons why in Latvia it might be a less problem to a lesser extent is, first of all, how the care is arranged in the country, how maternal care is arranged, what is the coverage, and other is general economic situation. I believe that in Latvia, when you compare to Romania, the general economic situation is better, and this might be an indicator why women didn't perceive such a financial burden. And also the fact that in general, for maternal care, this is not an unexpected event, and you can prepare for it. So then you are also maybe more prepared to spend this money. That's my view on first question. And the second, what could EU actually do to help the countries? And I want to now relate to one of the propositions in thesis, which is number 8. About EU, number 9. I will read it out. There should be more equality in access, affordability, and quality of care within the EU. And we know that health system is the responsibility of a single country. And this is why also there are differences found in care systems.
But
and also
just, you ask for it. So what should Europe do to achieve this field?
Yes, in my view also, as I'm writing here, that there should be ensured more access, and we should have more affordability and better quality. The question is what Europe can do in this respect, which is not overriding the rights of these single member states. And I think that one thing would be perhaps looking at quality. If there are some quality standards that could be that should be employed in each European country, and that could be maybe a factor that could already help. Maybe there could be some quality indicators for maternal care that should be followed by all countries in the European Union that could at least improve the appropriateness of care. And also the use of medical guidelines. If you think of that, then we saw that in some countries, the medical guidelines had more a suggestive, how do you say that, a suggestive power, and in other countries, they had to be followed. And these are also countries within the European Union, which indicates that there are differences among the different countries, but also within a country. And the difficult part is that, health system and arrangements of health system is a responsibility of a single country. And of course, we cannot apply the rules and regulations and the whole system in one country to completely plug it into another country, because there are so many other factors as cultural aspects, historical aspects, the economical capabilities, and also how this health system is looking right now. But I hope that there's...
May I just, before you make up the whole... No, of course there are possibilities of the European Union. For example, the European semester, there are country-specific recommendations that can cover health too. And at the moment, at the European Parliament, there is a discussion between the Polish ministers and Ms. von der Leyen about the 60 billion, I think, is it, structural funds that are not given to Poland, perhaps. So this could be something, for example, too. And this is linked to certain criteria that can be used in the healthcare system too. But thank you for your outline. I hand back.
I hope this at least partly answered your question.
Yeah, no, it's fine.
Thank you very much. The opposition will be continued by our external member of the assessment committee, Dr. Erika Richardson. She is honorary associate professor of the London School of Hygiene and Tropical Medicine. And for the candidate, maybe you can keep a little bit more distance between the microphone and yourself.
Thank you very much. Dear candidate, I was particularly interested in your thesis, in the more qualitative work that you did in Georgia and Latvia. And I felt they provided very interesting insights into the complexity of informality within health systems, whereas the traditional focus has always been on informal payments. So my question to you is whether you feel countries could eradicate informality in health systems without tax reform. What other approaches could they do, given that the wider informality within a health system is linked to things like personal contacts to get better quality care, what is perceived to be better quality care? So how can we tackle informality in our health systems? Or is it just a matter for the tax system? Thank you.
Esteemed opponent, thank you for the compliments and thank you for the question. Informality indeed is a very, very big problem, as you can see that in many chapters of my dissertation. And if you're thinking of how to go about it, I think it is such a complex issue, and that's why there is not one single solution that will work or that could work. And if it was so simple, then these problems were solved. But so what have some countries done in order to go about at least informal payments were to allow for formal fees. So for example, in Georgia, what they did, and also partly in Latvia, the private sector is quite well developed, and therefore those fees that used to be informal before are formalized. But that doesn't solve the whole issue of informality, as you are mentioning. There's still, even though you are paying for care officially and out of pocket, women still feel the need to ensure that they are safe, that they will have adequate care, that they will be treated with respect, and they do so also with establishing connections and seeing like ensuring that exactly this provider is going to treat me, and then I know that in my fragile state during birth I'm not going to be mistreated. But how to go about this? I think this is a wider societal issue, and also these informalities are there in place, but how to reverse them. So I think from working from two perspectives, from the provider's perspective, like targeting those, but also the society. Also, women need to understand that these informalities, for example, bringing informal payments, not in form of cash, but also in form of goods, that this is not acceptable, that this is not normalized anymore in culture. And I think that also needs to be changed, because if we simply would see from system perspective and we would not accept anymore any fees, then women still maybe would feel the need that they are still not safe, and they still want to ensure, and they still want to look for provider where they would feel in safe hands. And also to not normalize it or to not allow it from the care provider in the healthcare setting. So better governance in that sense, not only having this making the payments from informal to formal, but also generally having better governance, and that these payments are not allowed anymore, but that there are also consequences for allowing such payments. And
okay,
also,
sorry, if I could just jump in. Surely a formal payment is still a barrier to access. It's just something that can be taxed. It's not, an informal payment is no less or greater barrier to access than a formal payment, surely. And secondly, is the informality in the system something that, is it the problem, or is it the solution to a different problem? So are we using informality to get the quality of care that we want, or is it a problem in and of itself?
Yeah, I think we have to look here at the reason why these informalities are in place. If these informalities are in place because women need to ensure better quality, then maybe we need to do something about the quality of care, and then women would trust the healthcare system and trust that they're in safe hands, and there would be no need to use such informalities, such as by these informalities I mean that you are knowing some healthcare provider, or you know that who is going to treat you, and by that you know that you're in safe hands. If a woman could trust that whoever has a shift at that time, she's giving birth, she's going to be in safe hands, and no complications will be unnoticed, then there wouldn't be a need for such informalities. Also, if there were no long waiting lists, you didn't need to take a phone and give a call. I know you. Do you have a free spot? Can I come because I feel something is maybe wrong? And then, yeah, that person is accessing care faster, coming to see the provider. But other people who don't have such relationship with the provider would not would maybe then have as a consequence a longer waiting list. So this is creating these inequalities in access too. And even if when the situation is improved in terms of quality, then I think also women need to be informed that there are some quality improvements, and they can be reassured that it is okay to trust. And this is a different field. Maternal care woman is very fragile during birth, and I can only imagine how it feels when you were there and you haven't ensured that you don't have that trust in the system, and you don't know who is going to treat you, and you have to, besides what is going on in your body, in your mind, that you need to worry how someone is going to treat you, whether you will be treated with respect and dignity. And I can say from my experience, 25 hours in horrible, horrible pain. But you know what made my experience actually good, that I can look at it and say, yes, I struggled insanely, but I made it. There was a moment when I thought, I'm not going to make it. And then at that point, I really knew I'm in safe hands. You know, I am there. There's people next to me, and there was a whole team next to me, starting from my husband, midwife, care providers, everyone who just cheered for me. And I can only imagine how it feels when you have to think, oh, can I now say so? Am I allowed to scream and show the pain, because maybe they will yell at me? So, and you know, because there is this trust to care system, you don't need any informalities. I didn't mind which midwife will assist me in birth. And I think this is something that would be really great for our women in Eastern Europe, to just know that they can trust when they are the most vulnerable.
Thank you very much. Thank you.
The opposition will now be continued by Professor Gunta Lasdane. She is also online, and she is Professor of Reproductive Health of Riga Stradiņš University. The word is yours.
Dear Commissioner, dear Elina, happy name day, and Latvians are celebrating name day. I can't, of course, I'm to confirm that we're from the same original country, Latvia, and I really would like to compliment you with the depth and original research you have carried out in so many countries, and very diverse, with a lot of methodologies and interesting results. So thank you for that. But of course, as opposition, I have quite a number of questions. So I'll start with some, and of course, we'll see whether there will be some more time for others. So you emphasize a lot the importance of the knowledge and skills of maternal health providers. And I fully agree that that's very, very important. However, I'm also a teaching staff in the university now. And you have mentioned that the curriculum, medical curriculum in the Central and Eastern Europe should be overhauled. So that means all we are doing so far is not the optimal. How you really see, how would you give us those teaching in Eastern Europe and those countries you have mentioned? What would be your recommendation? How to proceed with your suggestions and recommendations?
Highly esteemed opponent, thank you for compliments. Thank you for congratulating me on my name day. And when thinking of the medical curriculum that was found to be outdated in many Eastern European countries and thinking how to go about it, then one thing that comes to my mind when looking from the perspective of my dissertation is the competency of communication. I think that competency, if that is a part of the curriculum, when the upcoming providers in future are trained on how to communicate with, in this case, women, but more generally with their patients, that also the patient is more put in the center of care. So the patient-centered care, that direction, I think that would be a very important component, because the knowledge and the skills of care providers, I was asking this to women and care providers. So this is only from the perspectives of women. So these are perceived. So this is the perceived appropriateness of care. So of course, I was not measuring the clinical quality. So oftentimes the clinical quality is good, but for women, if they don't feel safe in in providers' hands, and if they are mistreated, so it's more than only physical layer of taking care of pregnancies and birth. it's also psychological. And the communication is very important because it also shows that it can be a barrier to even seek the care. So if they are mistreated, if nothing is explained to them or little is explained to them, maybe they experience some other barriers and they accumulate, and in the end they are skipping the visits. They're not going to seek the provider. So we really, and seeing how vital, how important it is to seek maternal care to avoid these very avoidable causes of morbidity and mortality, then I think that communication competency would be something to start with.
I'm happy you are really prioritizing competencies, communication skill, because this is something that we have introduced during the last few years in our university. So at least in Latvia, it will be done. But thank you for that. So I go for my second question because I have time for that. So you emphasize that there's a lack of reliable, easy, accessible information regarding pregnancy, childbirth, and postpartum period in one of the main challenges in many Central Eastern European countries. You have confirmed this statement. So this problem is closely related to low health literacy, as you have mentioned, of many women, and existing myths and misconceptions. As you have studied thoroughly, not only published literature sources, but had interviews with women, what would you suggest as a next step in provision of such reliable, easy accessible information? And I would say in COVID time, it's even more important than before. So could you please give your suggestions, because we are to, again, follow them.
Thank you for your question. Before giving a direct answer, I think it is important to keep in mind some cultural aspects too. And also the way people usually seek answers to their questions. It also, so this how much people rely on their networks, how much people they rely on informal sources of information. I had the impression that there it is much more established, or it's much more likely that people are receiving answers through the informal networks, and so maybe that also on one hand complicates the problem, but on the other hand, it is also good if women are trying to seek advice in their networks of friends and family who had experiences. But you also mentioned that there are different myths, and so the information received might not be of high quality. And how to go about it? Well, I think it's a very tough one and a difficult one, because it involves it involves society. So how to communicate that? I know that, for example, in Latvia there is one trustworthy source, grūtniecība.lv, where women can see. So it's pregnancy.lv, where women can follow their pregnancy week by week and see what is. There are different recommendations based on evidence that are suggested, but apart from that, another information point is their maternal care providers, and I think that's also a very trustworthy source. But the little challenge is that the time of the visit, it's not unlimited. So there are these 30, 20, 15 minutes. It depends which provider, depends which facility. But there's just so many questions you can ask and so many answers you can get. But perhaps if there is, what now comes to my mind, if there is good communication between the provider and the woman, then woman also can open up and ask really these questions to the provider, instead of silencing them inside her and then asking them to their mothers, grandmothers, and friends around. So it's very, I think it's very difficult to overcome it, how to make women follow more trustworthy sources. Internet is full with everything. The social media, so many networks you can follow. and it's difficult to filter the information.
Elina,
so I think
promise difficult question. I promise difficult question. So you see, it is difficult. And yes, you have raised a very important problem, but honestly, it's not that easy. In general, you have recommendations. However, it's not that easy to follow them, because when you go to practical actions, it's a lot of questions again. So I hope that you will go on with research and help us to implement them. Recommendations you have as a conclusions have really made of your research work. So thank you, Elina. Let's go.
Thank you very much. The opposition will now be continued by Professor Jan Nijhuis. He is Emeritus Professor of Obstetrics and also the Secretary of this Assessment Committee.
Thank you, Mr. Prorector. Dear candidate, first of all, congratulations with your thesis, beautifully written, also for your team, of course. But I'm a bit surprised. It's a nice thesis, but when I read it, I thought, oh, these countries, they're not doing well. And that's also what you're telling us. The last half hour or so, you have discussed it's all in communication, which obviously is not true, not all of it. And you're not doing so bad as you are writing in your thesis. I mean, if you look at the cesarean section rate, also in Italy, in the southern part of Italy, it's 61%. In the northern part of Italy, it's 24%. So, yes, we have differences. Also in France and Spain and Portugal and the Netherlands, we have rural areas where everything is not available. Also in the Netherlands, we have a restricted possibility to get epidural in 30% of the hospitals 24/7. We have also post-traumatic stress syndromes, which you will also have in Latvia, also in the Netherlands. Yes, we have socio-economic problems. If you walk through Rotterdam from left to right, perinatal mortality increases just by in a few kilometers. The outcome is different. So a lot of things are true in Latvia or in Moldavia, but also in the Netherlands or in France or Italy. And I was surprised that you don't compare your data with the Europeristat data. That is strange because we have written nice reports under the leadership of Jennifer Seidlin in Paris, and your country is part of the European Union. And then I see the figures and I see that you have, for example, 24% cesarean section rate. I'm not talking about repeat cesarean section rate. The median for Europe is 25. I mean, the WHO thinks that it should be lower, you can discuss that, but you're not doing that bad. Moldova is a poor country, but has only 20% cesarean section rate. Mm-hmm. So it's not about being poor per se. So I would like to compliment you, first of all, that your country is not doing that bad. And you could get more possibilities to improve if you say, oh, we're not doing so bad, European Union, but we can do better. And you could say to your own people, we can do better. And I have the feeling that you started with saying, we're not doing it at all. That's not a Dutch philosophy. The Dutch always say we are great, which they aren't. They say we are the best in football and they lose and lose and never be a champion. So is that a mindset?
Highly esteemed opponent, thank you for your compliments on my thesis, that it's interesting, and also for the many questions or many points that I can comment on or that I can give my answers to. The final question is whether that's a mentality to say that we are bad. Maybe I need to seek out to my other opponent asking whether that's really a mentality. I don't think this is a mentality to say that we are so bad. The aim of this dissertation was to find out what are the barriers that exist. Because many times the only we see such macro level indicators such as C-section rates, maternal mortality, economic indicators, the public care coverage, and this is something that's very easy to compare. But my aim was more looking at the service indicators and look at the not so much at the macro level and reveal the problems that are sometimes or oftentimes concealed. And yes, I think I know that there is also mentioned. It is also mentioned in my thesis that in the systematic review that situation has improved in the past years. It has improved and it keeps improving. But we still cannot ignore the problems that exist there. And by identifying them, and the aim was to show people that the knowledge that these problems are there, not to close eyes. Yeah, they are here, but they're everywhere. Yes, they are everywhere, and they also shouldn't be ignored here. Also in the Netherlands, problems should be identified, and something has to be done about it. And when we are referring to C-section rates, Latvia and Moldova are really doing good.
Yeah.
Yes.
So you can be proud.
And also the Netherlands. But when we talk about Bulgaria and when we talk about Romania, more than 50% is not acceptable. And I was asking how many of the women had health complications, about 30%. So how do you explain that if they experience, only 30% of women experience complications during maternal period, maybe that's even after birth part of that. So why there are so many cesarean sections? Are there elective cesarean sections as well? And what are the factors that contribute to that? So it is deeper than that. Also this, and I don't say that these problems don't exist in some of the Western or Southern European countries like you revealed, Italy. But still, the aim of my dissertation was focusing only on the Eastern European countries, and therefore I was focusing on getting to know and capture the whole situation with respect to access to care from these 5 perspectives there. And
yeah, I understand that, if I may interrupt that.
Yeah.
But still, in Eurostat, you can compare some data, and I didn't see any reference to Eurostat. That's by itself. Well,
okay. Unfortunately, I cannot do this anymore because it's already printed and it's lying on your tables. But
yeah, but it's there, and even in Eurostat, you can see that that, for example, in the first-year mortality, you are doing better than the Netherlands.
That I know.
You're doing better, and you're improving. If you look at the 2 reports, then you see how your countries are really improving much faster than we are. So it's a compliment for your country. And keep up the good things, I would say. I would like to go to another question, which what intrigued me, and that's your proposition 6. One of your parnames can probably read out the proposition.
Okay. Number 6. If you want to know how strong a country's health system is, look at the well-being of its mothers. Yeah,
that's said by Hillary Clinton, who has just written a page-turner, I've heard, quite a detective. But this is another story of Hillary Clinton. What I'm curious about is where and when did she say it, and in what sort of context? Where did she get this knowledge and why? Do you have any idea about it?
Do I understand the question correctly? That you're asking about the background of the statement?
Yeah, where did she present it? Or I mean, America has much more problems than only the well-being of its mothers, I would say. But
I have to say that the reason why it is as a part of the proposition statement, a part of my thesis, is because it partly relates to my thesis, and this is why it spoke to me. I don't know why she was writing it, but if I can comment on maybe how it relates to my thesis and the situation here, is that not here, but situation in Eastern Europe. So by saying that if you want to look at the well-being of its mothers, you look at the country's health system, and it is partly true. It is true because maternal care is received and that depends on care system, because when you look at the broader level, not only within European context, East and West comparison, but going worldwide, global, then you see that states that are fragile, that have very, how do you say that? The health systems that are very, not fragile, fragmented, that's the word I was looking for, fragmented healthcare systems with little to no funding and the care coverage. Then if you see maternal care indicators such as maternal death and access to care on a macro level, you see that in those countries it is worse. So from that perspective, you could say that it really, healthcare system is very important for maternal health outcomes. But my thesis also shows that it's not enough. It's not only maternal care system. That it's also those macro and micro level indicators, more the social aspects as well.
Okay, thank you very much. I'm very satisfied with your answers, and I give back the word to the pro-rector.
Thank you very much, Professor Nijhuis. The opposition will be continued by Professor Marianne Nieuwenhuizen. She is Professor of Midwifery at our university.
Thank you, Pro-Rector. Dear candidate, I want to compliment you with this interesting and also informative thesis. As a member of the European Cost Action on Childbirth, I've worked with researchers from Latvia and Bulgaria and Romania. So I really was, your work helped me to understand a little bit more about this health system. So thank you very much for that. I want to talk with you about the indicators on micro level. They've been mentioned a couple of times in this meeting. They're at several places in your thesis. So I'm wondering, what do you have concretely in mind? What kind of micro level indicators would you like to establish and use?
Highly esteemed opponent, thank you very much for all the compliments on the thesis, and thank you for your question. By system level indicators, I meant, I was also explaining this today in my presentation, that there are more the number of healthcare facilities and the number of healthcare providers. But when we will go a lower level, then also we would need to look at the distribution of healthcare facilities. Then not only the coverage that women have, but even though the public health coverage says women are entitled to 4 antenatal visits, 2 postnatal visits, and so on. So what is the actual ability to pay for care for the rest, for the remaining fees? And these things like provider attitude and communication, these are not captured on the macro level, and that's why. And therefore, if you're only taking into account such macro level view, many problems that exist to access, that are barriers to access care, are concealed. Mm-hmm. They are not so visible. And by revealing these other problems that contribute also to accessing care, and there later to poor maternal health outcomes, they are important to be taken into account when evaluating the access.
So I was wondering, when I was reading about it, are you familiar with value-based healthcare and with the indicators developed by the International Consortium of Health Outcome Measurements?
Thank you for your question. Now it is it is
simple yes or no.
I'm a part of a research line which is value-based healthcare. And now it's a check of me, but how much I know about it. But if you want to ask a question, follow-up question based on some of those aspects, mm-hmm. maybe you could specifically refer to
yes.
some
So
part of those.
I was, you know, the indicators are also about satisfaction with care, about depression complaints, about mother and child bonding, such aspects. So do you think they should be part of a micro level indicator set?
Absolutely. because access to adequate care, this is why I was differentiating and trying to make very clear that there's a difference between accessing any care and accessing adequate care. And adequate care is not only quality care. Adequate is more than that. It's timely, it's patient-centered, it includes the care satisfaction as well, and also how mother feels and how baby feels. And when you refer to the depression and those conditions, then it is not only in this part of Europe where postnatal care is what women are least satisfied with, but also the most neglected part of maternal care. And I think a lot has to be done there.
Yeah, okay, that's what I heard as well. So another question. You included care providers in interviews, mainly looking at their perspective on women's access to adequate care and how barriers work for women. I assume talking with them that you also talked about the barriers they experience when performing adequate care, when towards women-centered care. So could you elaborate on that, what came up in the interviews you did with them?
Thank you for your question. Yeah, so this questionnaire, these in-depth interviews were done in 2 countries, in Georgia and in Latvia. And in each country has slightly different problems or different barriers to access care. And also providers are experiencing their working conditions and their situation differently because of very different contexts and very different care systems. The question was can you repeat it again?
What they experience as barriers towards women-centered care. So from a care provider's perspective.
The questions were asked on these 5 aspects of access to care, and they were so the interview guide was developed to be very similar to the questionnaires and group discussions that were held with women. The only difference was that it was a little bit adjusted on some aspects of use of medical guidelines, for example, that women wouldn't know how to answer, but also that, of course, care providers are commenting on access to care on behalf of women, but from their perspective. So there were no direct questions in the interview guides that were prepared that would question how. So basically, these aspects that you were just asking. So it was not specifically investigating their position.
Perspective.
Yeah.
Yes, but no aspects came up. I mean, when you do an interview, you try to have a talk as well.
Yeah. And it's also, of course, the things that came up were also that part of the problem in all this access to care is also their position and their possibilities and their working conditions. So when you see that there's an increased shortage in especially inpatient care facilities in public sector, you can imagine that some factors what came up there were that the staff is overworked. They are supervising so many women at the same time, and they're underpaid while working those very long shifts of 24 hours, 12 hours, and working many over hours to compensate for the shortage of medical providers. They still need to think that at the back of their mind that are they able to pay their bills? And from the midwife's perspective, what is the role of the midwife in those countries? So when interviewing some midwives, it was clear that the role of midwives have to be strengthened there. But that's a very complex issue that I think needs more than a couple of minutes of explanation. But I think it would really help if the role of midwives was stronger in Eastern European countries, also from economic point of view, but that's
What
more than that.
WHO says as well.
Elena Mettenis, the time appointed for defending your thesis has passed now. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company will await the results of our deliberation and our return into this room.
Please all rise.
Misschien moet ik het boekje vasthouden. Dat is ook een leuke foto. Oh, ik net. Dit fotoboek. Really finds the camera. Yeah, he likes. Yeah. He likes photos. Yeah. He's like big phone as well. He knows when the camera is on. Oh yeah, scherm. Yeah. Oh, so knoopjes. Do you want to when you come back? Or? I should have it. Yeah. Well, maybe with huh? And then if it's not going well, then you can. Yeah, no, but.
to see you.